Hello and welcome to the renal system. We do hope that you enjoy your stay and have a wonderful time learning the inner workings of the kidney and its great importance to our survival as human beings. So today's aims is to do a quick recap of the gastrointestinal system, introduce you to the renal system structure and function, and explore the physiology of the renal system, and then at the end we have some questions on the renal system for you. Okay, a recap quiz of the GI system. In the presence of a pathology, which means a disease, this part of the body can be described as ulcerated, beefy, or hairy. Is it A, the esophagus, B, the tongue, C, the stomach, or D, the anus? This part of the body can be described as ulcerated, beefy, or hairy. Was in fact the tongue. There we go, there's your hairy tongue, seen in your patients who have neglected their oral hygiene and who may be dehydrated. The hairy tongue isn't actually hair, it's just an accumulation of unsloughed off papillae that occur on the tongue anyway, and food debris. So this sort of indicates that the patient really needs to tend to their oral hygiene. It's sometimes seen in end-of-life patients who aren't eating or drinking much or even speaking or cleaning their mouths. There's your beefy tongue. This is seen in your patients who have iron deficiency anemia, where the normal papillae slough off and it looks red raw and beefy and quite sore. And there's an ulcer on the tongue. Ouch. So the next question is the epiglottis. Does it A, keep the uvula central when swallowing, B, close the vocal cords when swallowing, C, close over the trachea when swallowing, or D, closes over the esophagus when swallowing? The epiglottis, right. Well, the answer was C. It closes over the trachea when we swallow. And there's an example of somebody swallowing something and down it goes, and there we go. The epiglottis successfully closed over the trachea and stopped it going down the wrong way. Or in other words, aspirating when fluids are accidentally poured into the lungs. Next up we have carbohydrates. So carbohydrates, can they be A, can be simple, for example sugar, B, can be complex, for example starch, C, are broken down by salivary amylase into glucose, or D, are broken down by pancreatic amylase into glucose? Well, the answer is A, B, C, and D. Excellent revision there on carbohydrates. So, peptic ulcers can be caused by exams. X factor, watching football, or Helicobacter pylori? Well, the answer is A, B, C, and D. And there's a little cartoon showing you some Helicobacter pylori, and Helicobacter pylori itself as a bug synthesizes a chemical called urease, which produces an ammonia which damages the gastric mucosa and can lead to stomach ulcers, and is treated with triple treatment there of omeprazole, clarithromycin, and amoxicillin. Next up, this is part of the colon. Is it the transcending, the impending, the expending, the ascending, or the condescending? Which one is it? It was D, the ascending colon. So there we go. The ascending colon's a bit in brown there. So you have the appendix and the ileocecal valve, the ascending colon, transverse colon, descending colon, sigmoid colon, rectum, and then a good old anus. So the renal stroke urinary system that we're going to talk about today. So we're going to go through the kidneys, the blood supply, the ureters, the bladder, and the urethra. There's a nice image there detailing the urinary system from upper urinary tract all the way down to lower urinary tract. Interesting to note that the adrenal glands are sitting on top of the kidney. There they are. Okay, there's your adrenal glands, like a little baseball cap sat on top of the kidney. So now I'm glad that you know where they are now. I'm trying to rub this off. There we go. So the kidneys, right? They are a pair of bean-shaped organs located in the posterior peritoneum. So posterior just means it's towards the back. So when you slap your posterior, you're slapping your behind, which is your bottom. Posterior means towards the back. So posterior peritoneum is towards the back of the abdominal cavity, near the middle of the back. So the right kidney lies slightly lower than the left kidney. Why is that? Okay, if we look at the image, there's your right kidney there. It's slightly lower, although not much, than the left kidney. The reason is because of the position of the liver. And there's your liver up there. So the liver, there's only a portion of the liver here. It's been cut away a little bit. And just for completeness, there's the spleen going on there. Spleening away. Spleen's a large area of lymphoid tissue, important in our immune response. Okay. Each is about the size of a fist, and the nephron is the basic structural unit of the kidney. We'll go into the nephron on the next upcoming slides. So there's a nice picture of a human kidney that's been chopped in half. It's got 3 layers. It has a renal capsule on the outside, which is this really, really thin bit at the top there. Okay, there's your renal capsule. And then it's got the renal cortex, which is this bit here. Okay. That's actually labelled cortex for you there. And then there's the renal medulla, which is the sort of like these bits here, the middle bits. Okay, and I think that's about it for this one. Although there is other things illustrated on here. We've got the renal pelvis, sort of like this area, sort of in the middle. So the urine is sort of made, and it goes into these collecting ducts and comes down the renal pelvis and leaves via the ureter. Okay, the ureter, you have one ureter for each kidney, and you have one urethra in which you pass urine out into the outside world. So next is the blood supply to the kidney. The kidney receives about 20 to 25% of one's cardiac output. So the blood goes in the renal artery, okay, and then it will be sort of run through the nephron. Okay, the glomerulus, and all the other stuff, and once it's done that, and you then get sort of the efferent arteriole goes into a little vein, and the veins all join together and form the renal vein. Then the sort of the stuff goes back to the inferior vena cava, and then urine, which is made, is collected, and the urine goes down the ureters and out to the bladder, where it is excreted via the urethra. Okay, so there is your renal artery going into the kidney. There is your renal vein, which is draining venous blood from the kidney. And there is the ureter, which is draining the urine away, which has filtered the blood. All the rest of these things that I mentioned on here, all of these sort of complicated sounding things, don't worry too much about them, but just know that they exist. Okay, I'm not going to test you on them in the exam. Okay, just know that your kidney itself has an artery, a vein, and it makes urine is completely acceptable. So the functions of the kidney are to excrete waste, to help maintain homeostasis, and hormone secretion as well. Here's just some additional nice pictures of the kidney. There's our adrenal gland on the top again. Okay, and if you look at the image on the left hand side, there is the adrenal gland living on top of the kidney. Okay, there's your kidney down there, and the associated blood vessels that go with it. This stuff about inferior pole, that just means the bit at the bottom. Superior pole just means the bit at the top. Lateral border just means it's the border that's on the side of the kidney. They all try and give them sort of complicated sounding names, but there's no really need, because it's just describing where the things are. And as previously mentioned, it has a renal artery going in, a renal vein coming out, and the ureter for the drainage of urine. Very straightforward. So the excretion of waste products from the kidney, the products of metabolism, for example, urea, uric acid, and of water, it filters the blood in the glomerulus and removes any unwanted substances. So you've got an afferent arteriole going in at the bottom there, and it goes through this lovely beautiful plexus of like a little artery thing, and the blood's filtered here. Lots of filtrate comes out from the glomerulus and is collected in Bowman's capsule. So there's all the filtrate getting collected into Bowman's capsule, then off it goes into the rest of the nephron. Okay, and this is termed glomerular filtration. So the glomerulus, that's filtering things. Guess what? It's called glomerular filtration. Okay, so the glomerular filtration rate can be used as an estimate of your renal function. So if not a lot of stuff is getting filtered, then your kidneys won't be producing a lot of stuff, basically, and therefore it's possible to indicate whether you're in a degree of renal failure. So here is a little diagrammatic representation of the nephron. So we start in the sort of the efferent, so the afferent arteriole goes in into the glomerulus, and the efferent arteriole comes out. And this filtered blood in here, this is all of the filtrate. It goes along what's called the proximal convoluted tubule, and then it goes down the descending part of the loop of Henle, goes around the loop of Henle there, and then the thick ascending limb of the loop of Henle, and then into the distal convoluted tubule, and then into collecting ducts, which in essence at this point you've got the urine. So that's how sort of wee-wee is made, and I only say wee-wee because I have two little kids. It's the urine, basically. Yeah, points along the way, different things like water and salt reabsorbed, or sometimes they're actively excreted in order to make sure that the homeostatic balance of the body's urea and electrolytes is maintained at an appropriate level. So the nephron, there are three processes that happen in the nephron. Just expanding a little bit on what was said in the previous slide. We have glomerular filtration, where the blood is filtered through the glomerular capillaries into what's known as Bowman's capsule. Thereafter, bits of it get reabsorbed, so the filtrate will pass into the tubules, as we previously mentioned, where substances are reabsorbed back into the blood. And then thirdly, we have tubular secretion, with secretion of substances to be eliminated by the body. There's just some notes on here. So filtration is blood passing through the glomerular capillaries, is filtered under pressure into Bowman's capsule. This is known as filtrate, and it contains water, potassium, bicarbonate, sodium, glucose, and amino acids, as well as waste products like urea and uric acid. So large particles such as blood cells stay in the capillaries, so they're not normally found in the urine. Hydrostatic pressure in the capillaries instigates filtration, so that means it's forced out. Hydrostatic pressure forces stuff out. Because the afferent arteriole, so that's the arteriole going in, has a greater lumen than the efferent arteriole. So if we look at that, so the afferent arteriole goes in there, and the efferent, like effluent, goes out. If you look at it, the size of that one's a bit bigger, and the size of that one's a bit smaller. Okay, and that is going to create pressure in here, isn't it, inside the glomerulus. So if you have a big one there and a little one there, you're going to have increased pressure in there, and it's going to allow fluid to be forced out under what's called increased hydrostatic pressure. Fantastic. Then further along the tubule, you get reabsorption of solids. So this takes place in your proximal convoluted tubule. When it says proximal convoluted tubule, it just means it's the first bit of the tubule, and it's convoluted, so it's just twisty and turny and goes all over the place. Reabsorption of water takes place in the late portion of the distal convoluted tubule. So further along, after the loop of Henle, water gets absorbed in the distal convoluted tubule, and this is dependent on the presence of a hormone called antidiuretic hormone. So antidiuretic hormone prevents diuresis, and if I give you a diuretic, it will make you wee. Yeah, so diuresis is to pass a lot of urine, and the presence of this antidiuretic hormone helps us reclaim our free water, and we maintain our homeostatic levels. If we don't have enough ADH, we'll just have a diuresis, actually. So inability to produce the antidiuretic hormone, which is made in the pituitary gland, would result in a condition called diabetes insipidus. Yeah, so you'd be producing a load of urine, and if you were to drink it, it would taste insipid, because it would be mostly water. So that would be your diabetes insipidus, as opposed to diabetes mellitus, which is to do with insulin, where mellitus just means honey flavored. So if you were to drink the urine of somebody who has diabetes mellitus, it would taste of honey. I don't want you to get the impression that I have a thing for drinking urine. It's just what was done historically in the past. Doctors would taste the urine of the patients in order to determine if they actually had diabetes mellitus, or even in some instances diabetes insipidus. Anyway, there is active secretion of substrates transported to the collecting tubule for excretion. Yes, good. Yeah, there's your tubular secretion happening there. So there's our nephron there. There it is in all of its glory. Isn't it a wonderful thing? Okay, so let's take a little journey through it. We're going to go through the afferent arteriole. Remember, the afferent arteriole has a big wide opening, and then into the glomerulus. And because the efferent arteriole has a little bit smaller sort of lumen, you're going to have increased hydrostatic pressure in this glomerulus here, which is going to force fluid out to be collected in Bowman's capsule. So there it goes into Bowman's capsule, and on its journey it then goes through the proximal convoluted tubule, lovely there, down the thin descending limb of the loop of Henle, around the loop of Henle, then up the thick ascending limb of the loop of Henle, then through the distal convoluted tubule, and then to the collecting ducts where we have urine, and then make their way down the ureters into the bladder, and then excreted to the outside world via the urethra. Okay, and if you were stood inside the adrenal cortex and you were really, really tiny, this is what you might see. Millions and millions of nephrons, little functional units. It's really, really cool. You can sit and look at that for a while. It's quite therapeutic. Quite enjoy that. Good. Right, and there's another small image there. So there's about 1 million of these in each kidney, and the kidneys are regulated by hormones. So we have ADH, aldosterone, and parathyroid hormone. So ADH itself, antidiuretic hormone, helps you reabsorb more free water, and what that does, that expands your plasma volume so that you can maintain your blood pressure in essence. So ADH is really quite important, and if you don't produce enough ADH, you will have lots of diuresis, and you will have what's called diabetes insipidus. Aldosterone is released by your adrenal glands. It's released by the adrenal cortex, and aldosterone helps with the reabsorption of salt. Okay, so if you have more aldosterone around, you will reabsorb more salt. Now, what's the point of that? Well, in order to maintain a nice osmotic balance in your blood, you need appropriate amounts of water to make sure you either don't become too salty or not salty enough. Okay, so aldosterone will reabsorb more salt, and with that you will therefore have obligated water that will have to come with it in order to maintain that homeostatic balance. So if you absorb more salt, you will absorb more water, and that will increase your blood pressure. So I suppose that's one of the reasons why having too much salt in your food can increase your blood pressure. Then we also have parathyroid hormone, and that is very important for the regulation of calcium. Calcium itself, most of it is stored in our bones, but it's also needed. Calcium is needed to metabolize enzyme reactions all over the body, and parathyroid hormone will increase the reabsorption of calcium from the kidney, so that you can maintain your normal calcium levels. So a couple of little notes there. Your parathyroid hormone, which I've already mentioned that. That's to do with your calcium reabsorption. Antidiuretic hormone is to do with absorption of free water. Aldosterone is to do with reabsorption of salt. Okay, actually, the aldosterone, it is formed part of the thing called the renin-angiotensin-aldosterone system, or the RAS, renin-angiotensin-aldosterone system. So this is how your body maintains your blood pressure. It's pretty cool. What happens is you've got little cells that live near your glomerulus called juxtaglomerular cells, and they can detect changes in blood pressure. And if the blood pressure gets a bit low, okay, it goes, oh, we need to have higher blood pressure in order to keep the person alive, and also keep the kidneys functioning, really. So those juxtaglomerular cells detect a drop in blood pressure, and they go, oh no, we need to maintain blood pressure. So release So, renin. The juxtaglomerular cells release renin due to a reduced blood pressure. Okay, what renin then does, it converts angiotensin 1 to angiotensin 2 in the lungs. There's an enzyme called angiotensin converting enzyme in the lungs. And when you have angiotensin 2 about, what that does, that works systemically all over your body to cause vasoconstriction. And that is constriction of the little precapillary sphincters and stuff, constriction of your smooth muscle to increase your blood pressure, to increase that venous return to the heart, to increase the stroke volume of the heart, which increases the blood supply to the kidneys, which is excellent. It then also encourages the release of aldosterone, and we mentioned aldosterone for the reabsorption of salt as well. And it will, additionally, it will also stimulate your pituitary to make a little bit more antidiuretic hormone as well, to really suck that water back. Now, the renin-angiotensin-aldosterone system is a thing that people just get high blood pressure as they get older. So what causes that? What causes the reduced blood supply to the kidney? Well, sometimes it's caused by narrowing of the renal artery and a thing called renal artery stenosis, caused by atherosclerosis and atherosclerosis. But most of the time it's idiopathic. In other words, they don't really know what causes it. So you can treat this with ACE inhibitors, so angiotensin converting enzyme inhibitors, that prevents angiotensin 1 being converted into angiotensin 2 and prevents all of that vasoconstriction. So that's one of the things that you can use. Management of hypertension is something that you'll become familiar with throughout your training, but at least now you've been introduced to the idea as to the mechanism that it works. It's called the renin-angiotensin-aldosterone system. So, homeostatic balance in the kidney is achieved via the reabsorption of water and substances in the renal tubules, okay, and also with the maintenance of a thing called acid-base balance, okay. What is acid-base balance? We're talking about here the blood pH of 7.35 to 7.45. So pH stands for percentage of hydrogen, how many hydrogen ions there are in a particular substance. So something like hydrochloric acid might have a pH of 1, for instance. Okay, it's very acidic, where pH 7 is neutral, and pH 8, 9, 10, 11 gets progressively more alkaline. Now, things that are strongly alkaline can burn just as much as things that are strongly acid. So your sort of blood in itself is slightly alkaline. You're sort of like leaning towards the alkaline end rather than neutral, but it's still 7.35 to 7.45. Okay. If you have too much acids on board, you become acidotic, and it is termed acidosis. Okay, and there are two different types. There's a metabolic acidosis and a respiratory acidosis. Okay, so a metabolic acidosis might be due to a decrease in bicarbonate, for example. Acidosis in itself, if you have the sepsis, if one is septic and you have a bacterial infection and it's making you septic, okay, you can produce a lot of lactic acid. Okay, why would you produce lactic acid? Well, if your body is really trying very, very hard to mount an immune response, okay, and all of the body systems are working very, very hard to keep your temperature elevated, and your blood pressure might be really, really quite low down, and your heart might be working really, really hard to try and get oxygen to all of your tissues, but because you're getting overwhelmed by infection, your heart really can't deliver that oxygen to the tissues as much as the tissues want it. So you get a mismatch between the amount of oxygen demand by the body tissues and the ability of the body to supply that. And what the cells in your body do then, they revert, they change their method of surviving, of metabolizing. Normally cells use oxygen, and it's called aerobic respiration. So they will take the oxygen in, and they will use that, and they will engage in their cellular processes for the production of ATP using oxygen and other things, right? But if there's not enough oxygen, what they will do, they will switch and they will start making ATP via anaerobic respiration. A means without. So if you have your cells respiring anaerobically, this is a very inefficient way of producing ATP. The cells won't be able to make enough energy to sustain themselves for very long, and you do get a byproduct accumulating of anaerobic respiration, and that would be lactic acid. So when your patients come in and they are possibly septic, they will do what's called the lactate levels. So if they'll test the patient for lactate level, and if it's too high, it can make them acidic, and then they will have a metabolic acidosis. Okay, you can get a respiratory acidosis as well. So this is where your lungs really, you're not breathing enough. Okay, when one breathes out, okay, we excrete carbon dioxide. Now it says there due to an increase in carbonic acid. Now carbonic acid is what you get when you mix carbon dioxide and water. And you breathe out your CO2, and therefore you reduce your levels of carbonic acid. So if you're not breathing out your CO2 enough, you'll accumulate your CO2, your carbon dioxide, and you'll begin to get acidotic. From that point of view, that will be a respiratory acidosis. Acid-base balance, you can get confused in it, but it's relatively straightforward. You can think your way through it. Okay. It can do with the regulation of our electrolyte concentrations. Electrolytes, literally an electrolyte is something that will allow electricity to be conducted through it, and regulation of fluid volumes. Okay, I'll now talk a little bit about alkalosis. Okay, I mentioned acidosis before. So if your blood pH goes down too much, so if your blood pH goes below 7.35 and 7.25 and like 7 and then 6 and then 5, then you're going more and more acidic. Okay, but equally it can go the other way. You can get an alkalosis. Okay, you can get a metabolic alkalosis due to an increase in the amount of bicarbonate that they've got on board. And it's possible to get a respiratory alkalosis due to the decrease in carbonic acid. So if you hyperventilate a lot, it is possible to give yourself a little bit of an alkalosis. Equally, you can get an alkalosis if you vomit a lot. Okay, if you spent the day vomiting, okay, you've vomited up a lot of things from your mouth, and you've got rid of a lot of hydrochloric acid. There's a lot of acid in that. Okay, so you've got rid of a lot of hydrogen ions. Okay, so in order to try and maintain your pH, if you've vomited out a lot of hydrogen ions, you're going to end up being acidotic. So your body will try and compensate from that by increasing other acids in other ways, like reducing your respiratory rate in order to try and compensate for that. It's called respiratory compensation. That's very, very dangerous. So acidosis and alkalosis, they're relatively logical, but at this point in your training, I know that was a long description, but this is just to help you understand that it's important that from a homeostatic point of view, your blood pH is kept at 7.35 to 7.45, and your kidneys facilitate acid-base balance. All right, that's what there is. Now, there's a long-winded explanation, but don't get too upset by it. It was just to know that your acid-base balance is something that is maintained by your kidney. Okay, yeah, regulation of blood pressure, which we have mentioned already with the renin, angiotensin, aldosterone system. Yeah, renin is by your juxtaglomerular cells, which detect a reduction in blood pressure. They will then sort of work along with the renin-angiotensin system to increase your blood pressure. And aldosterone, well, angiotensin gets converted to angiotensin 2 in the lungs, and that is a vasoconstrictor, and that will help with that will facilitate your kidneys, your adrenal glands to produce aldosterone to make your kidneys absorb a bit more salt to increase your plasma volume and increase your blood pressure. Okay, hormone secretion. So your kidneys can also secrete a hormone called erythropoietin for the increased production of blood. So if you are hypoxic, this is explained here, hypoxia, hypo means low, oxygen. If you're hypoxic, your kidney will release a hormone called erythropoietin, and this will tell your bone marrow to rev itself up and start making more red blood cells. So you'll increase your blood cell count. Okay, and in doing that, if you increase the oxygen carrying capacity of your blood, you should cure the hypoxia. Stands to reason, doesn't it? But one thing that you can get with that is that if you have too much erythropoietin on board, your blood can get a little bit too thick and you can be at risk of clotting. Erythropoietin is one of the hormones that people who want to cheat at sports take, EPO, they call it, and they risk their lives because they put themselves at hugely increased risk of getting a clot. Okay, secretion of renin, which you mentioned in the renin-angiotensin-aldosterone system for maintenance of blood pressure. Antidiuretic hormone, well, this is made in the pituitary gland, but this acts on the kidney and facilitates the reabsorption of free water. It's made in the posterior pituitary. There we go. And your kidney also helps with the production of vitamin D. There's a few different stages that vitamin D goes through in order that it is to become metabolically useful to your body. It gets processed in your liver and it gets processed in your kidney before it can be utilized by your body. Okay. Okay, so we've been through the kidney, the nephron, and now we're down to the urinary bladder. So, gravity and peristalsis. Peristalsis we covered in the gastrointestinal lecture, where you've got a tube that's got smooth muscle in that contracts. Okay, so the bit sort of in front of the bolus relaxes and the bit behind the bolus contracts, and it does that in a rhythmic wave, and that helps propel the urine along the ureter to make its way into the bladder, and then the bladder will eventually get full up. Okay, so there's your peristaltic activity happening. Okay, so when the bladder is full, your parasympathetic nerves will contract the detrusor muscle, and micturition will result. Micturition just means having a wee, but micturition or urination, but micturition is the sort of textbook term. Okay, you'll only get micturition if the internal sphincter, which is under involuntary control, that's when you sort of get the urge, and the external sphincter, which is under voluntary control, relax. Because I'm sure we've all been in situations where you get the urge to you need to go and micturate, and it is not convenient just because you might be stuck in a queue for said toilet, so you literally have to wait. So voluntarily you hold on to it until it's convenient for you to pass urine. So the control of micturition, when your bladder fulls, your bladder will reflexively contract. Okay, so it will just want to eject its contents when it's full. So when it's full, the internal sphincter will open, and stretch receptors in the bladder wall will send some inhibitory pulses to the external sphincter, which is under your voluntary control, and voluntary signals from the cerebral cortex can override this reflex, or they can allow it to take place. So the top and bottom of that is you can choose whether or not you wish to micturate when your bladder is full. Having said that, when you're gonna go, you're gonna go. So there are limits to which one can voluntarily hold on to it. Occasionally, people can go into a thing called urine retention, where the internal sphincter just clamps shut, and the bladder fills up and stretches and stretches and stretches, and it can be very, very painful and can lead to renal failure and death. So patients can go into urine retention for a number of reasons. You can go into urine retention if you've had a general anaesthetic, for instance. So they don't like to let you home if you haven't had a wee after your operation. You can go into urine retention if you've had a spinal anaesthetic. Another thing that's very, very common. You can even go into urine retention after you've had a catheter in. So it's important to make sure your patients are not in retention. So you've got the voluntary thing, the involuntary thing, and retention as well. But yeah, you really most of the time you can only hang on to it for so long, and eventually it will come out. Next we have blood creatinine and urea. So these are used as renal function tests. Urea is synthesized in the liver as a waste product of protein metabolism, and creatinine is a waste product of muscle metabolism. Right, renal failure is next. So renal failure can be acute, it can be sudden onset, and it's usually reversible. It can be chronic and progressive, and that can be irreversible. Up to 75% of renal function can be lost before it's actually noticed. That's a thunderingly big amount. Renal failure itself can be pre-renal, renal, or post-renal. Okay, pre-renal means that there's a drop in blood pressure, so there's something wrong with the pump supplying the blood to the kidney, so the kidney can't make as much urine, so it's pre-renal, so it's before the kidney. Yeah. 2 is intra-renal, so there's actually something damaging the kidney itself, something's damaging the inner workings of the kidney, such as toxins or drugs or infection or something like that. Yeah, it's intra-renal failure. And you can have post-renal, so that means obstruction to the outflow of urine somewhere along the line, something like a enlarged prostate, or even a blocked catheter, or a tumour or something like that. So renal failure itself, weirdly enough, can be pre-renal, renal, or post-renal. Okay, so just a little recap there. Acute renal failure can develop quite quickly and can be serious. It can be caused by trauma, a virus, myocardial infarction, obstruction, glomerulonephritis, hemolytic uremic syndrome, and it is usually reversible. Chronic is progressive and irreversible and can be caused by hypotension and diabetes as well. You can get a thing called diabetic nephropathy. And end-stage renal failure, the kidneys permanently fail and the patient will go on to die if they are not given renal dialysis or a transplant. Okay, this is just to show you the stages of chronic kidney disease. We've got stage 1 to stage 5. Don't worry too much about this. You won't be asked about this in your exam. This is some background information for you to see from an illustrative point of view the stages that the kidneys go through when they are failing. They go through stage 1 to stage 5. And we've got another column that shows you the glomerular filtration rate expressed as a number, and you can see how that decreasing as the kidney sort of failure increases, and then the percentage of kidney function that you've got there, you can see that sort of like decreasing as it goes down. So it's just to have an appreciation of these sort of like there's more, you're more than in just like failure. Yeah, it can go through stages, and it can correspond to the glomerular filtration rate, and that is a representation therefore of how much kidney function that you've actually got left. Okay, so we're just going to talk through some of the things that you can get in chronic renal failure. So these patients can get headaches because you're not filtering the things like the ammonia and creatinine and things like that, and they can cause you to have a sore head. You can have a decreased ability to concentrate urine. So this means if you have concentrated urine, it tends to be more darker. The first morning void tends to be really quite concentrated, so it's possible in renal failure to lose your ability to do that. You can have polyuria, which means lots. Poly means many. Urea is just sort of having a wee, so having lots of wees. You can have that. It can go to oliguria. Okay. Olig, which is small amount of urea, and you can even go to anuria, where you don't produce any urine. You can have an increased blood urea nitrogen and increased serum creatinine. It's a byproduct of muscle metabolism. You can get edema, which in England is spelled with an O, so it's edema, so that's how you spell it in England, with an O on the front. The glomerular filtration rate can progressively decrease. You can get a mild anemia. Think that through. Why might you get an anemia? Well, your kidneys produce that hormone, don't they, called erythropoietin. So if they're in failure, they mightn't be producing the erythropoietin. Increased serum potassium because you're not filtering it out. You can get an increased BP because your renin-angiotensin-aldosterone system might be firing loads in order to try and get some more blood supply to that kidney that's suffering. And overall, you can end up with weakness and fatigue as well. So many things can happen in your patients who are having the renal failure. So next is hemodialysis, and there are a couple of different ways of doing this. Your blood can be sort of dialyzed in a dialysis machine traditionally. Okay, it's taken out of one bit and goes into the machine, gets filtered, and then goes back into the patient. So the different types of access for this. Sometimes you get a thing called a fistula made, where you'll have surgery to create a connection between an artery and a vein, so that that is used for your dialysis. Additionally, there's a thing called peritoneal dialysis, where the solution is the dialyzing solution is just literally put through a catheter into your patient's abdomen, and the sort of waste products are osmotically encouraged to enter this dialysis fluid, and that fluid's drained off. So that's another method of dialysis that occurs as well. So what is a UTI? A UTI is a urine tract infection. It's an infection in any part of the urinary system, from the urethra to the bladder, ascending up the ureters into the kidney. So, urine tract infections, the most commonly caused by a bacterium called E. coli or Escherichia coli. There are loads of different sort of breeds of E. coli. There's an E. coli that lives in your gut that helps you with the synthesis of vitamin D. So not all E. coli are bad. However, having said that, if you end up with a septicemia, so if any of them E. coli manage to get into your bloodstream, then you can get sepsis and die. E. coli is amazing. It has a replicative turnaround time of about 20 minutes. So it divides by binary fission, which means that one E. coli will become 2 E. coli in about 20 minutes. 20 minutes later, 2 will become 4. 20 minutes later, 4 will become 8, and so on. And so that gives you some idea of how quickly they can pass on the genetic material, and how quickly they can therefore evolve, and therefore how quickly they can establish an immunity to antibiotics. Okay, so most urine tract infections are caused by E. coli. It's mostly caused by bacteria from the bowel or vagina that enter the urinary tract through the urethra. Sometimes caused by fungi or viruses. They're very common. They're more common in women. Why? Well, women have a shorter urethra. Most UTIs are in the lower part. So where is the lower part? Okay, so you've got lower urinary tract infections and upper urinary tract infections. So your lower UTIs consists of your urethra and your bladder. And anything north of the bladder, okay, so anything from the sort of beginning of the ureters all up to the kidney is an upper urinary tract infection, like pyelonephritis or ureteritis. The further up it gets, the more serious it gets, because your patient is then at risk of being systemically unwell and getting sepsis. But that's not to say that a low urinary tract infection couldn't actually give you sepsis as well, depending on whether or not your patient was immunocompromised. But there we go. So there's lower UTIs and upper UTIs. So this was your group work. Make a list of factors that might increase a person's risk of acquiring a urinary tract infection. Right, so I think this is coming up on the next slide. So, factors that predispose you to getting a urinary tract infection. Anything that obstructs the urinary tract, for example, kidney stones. Kidney stones can be pretty small. I mean, you can see that on somebody's finger there, but they are very, very painful. If they remain in the renal pelvis, they can sometimes rattle around in there, but if any of them get into the ureter, they can cause ureteric colic, which is very, very painful. And the ureter will really cramp down and really try and get that stone passed all the way down. So you can imagine how painful it is to get a stone that big down a very, very thin tube that's normally used to just dealing with liquids, definitely not stones. So very, very painful. Difficulty emptying the bladder. So if you can't empty your bladder fully, so this might be more common in the elderly men who have enlarged prostates and are left with what's called a residual volume in the bladder. You can get it in ladies as well, but failure to empty your bladder properly means you've got urine sitting in there, and it's a lovely breeding ground for bacteria. People who are unable to feel bladder fullness, so your patients who have paralysis or your stroke patients might not be able to feel that they have a full bladder, and this can lead to your bladder being full for too long and possibly going into urinary retention, and this can predispose you to having a urinary tract infection. Diabetes. Why would somebody with diabetes be at an increased risk of urinary tract infections? Well, if you have diabetes, you have an increased propensity for passing urine that contains glucose. Glucose is not normally found in urine, but if you have diabetes and is not well controlled, if you are hyperglycemic, you will excrete some in your urine, and that will predispose you to urinary tract infections, as amongst other things. If you are immunocompromised or you have a weak immune system, if you're unable to mount an immune response to any invading pathogen. If you have an enlarged prostate called prostatic hyperplasia. Okay, hyperplasia just means an increase in the size of the organ due to an increase in the number of cells. Okay, and if you have a urinary catheter in place, because this is a foreign body in essence, which is being pushed up the urethra and is sitting on the bladder neck, so that the bugs themselves can just merrily make their way along this this foreign body, because your white blood cells can't get into the foreign body to attack any pathogens, so the pathogens just find their way in. Being female, unfortunately, increases your propensity for urinary tract infections, and increased sexual activity as well. In females more than males, but nonetheless can occur in males as well. What happens is that there's a phenomenon called honeymoon cystitis. When couples sort of get together and go on honeymoon, they'll have a tremendous amount of sexual activity and increase their likelihood of getting urinary tract infections because of the things that happen in and around the urethra during this activity. It's a lot easier for bacteria to make their way into the urethral orifice during this activity, especially if it's increased in frequency. So that's why it's always a good idea to have a wee after engaging in sexual activity. Okay. So group work, make a list of the signs and symptoms somebody may present with if they have a urinary tract infection. This will be on the next slide. Okay, lower urinary tract infection symptoms, urinary frequency, so needing to go for a wee more frequently, dysuria, so it can be very painful to go and have a wee. It can be burning as well. It can feel like you're sort of trying to wee razor blades. This can be caused by things like bacterial cystitis. There is a thing called painful bladder syndrome. There's also a thing called Reiter's syndrome, where the Reiter's syndrome is the sort of the old term for it, where you can get a sexually transmitted infection, which can give you a conjunctivitis and urethritis as well. You can get bladder stones or stones in the ureters, and also depression as well can cause dysuria. Okay, urinary urgency, so it's the urge to go right now, and the feeling that the bladder isn't empty. So as well as the frequency, when one does use the toilet, it doesn't feel like your bladder's empty because it's all inflamed and very, very unhappy. You can get suprapubic pain, so literally over the sort of suprapubic area is where you can get pain. You can get cloudy, foul-smelling or bloody urine, which is called hematuria. There's some nice cloudy urine. Your patient can feel unwell, can have aches and tiredness, and they can also have a pyrexia. And some patients can also get confused as well. So if you have a confused patient, it's worthwhile sort of like trying to investigate whether or not the patient may well have a urinary tract infection. So upper urinary tract infection symptoms is a pyrexia of 38 degrees or above, pain in the sides or the back, this is called flank pain, shivering and chills, nausea and vomiting, confusion, agitation or restlessness. And if you look at what does the colour of your urine say about your health, I suppose that when we get up in the morning, our urine is probably a bit dark yellow, and if you don't drink enough it can be dark yellow, but there's some things that can indicate things that might be wrong with you. Okay. Okay, urinalysis. This is analysing the urine. This includes visual inspection for its colour and its clarity, and if it's cloudy. Chemical examination to provide a lot of information, which is on the next upcoming slide. We can do microscopic examination for culture sensitivity. Culture means you try and grow any bugs that might be there. Sensitivity is it's tested with lots of different antibiotics to see which ones the bug is sensitive to. Cytology is where you can look at different types of cells that might be in there. Virology is to detect for any viruses, and mycology is to look for funguses. So urine dipstick, this is really important information to know. It's very, very useful to have this information. The way it works is the patient brings in the urine sample and you dip a dipstick in and then you have a look at it. Okay, so we're going to look for leukocytes. Leukocytes are white blood cells not normally found in urine. If you have lots of them in, even a moderate amount, your patient might have a urinary tract infection. Nitrites. Okay, now nitrites are a substance that is converted from nitrates. Bacteria convert nitrates to nitrites, so this can be a sign of urinary tract infection. Urobilinogen urobilinogen. Okay, this is a product of breakdown of your red blood cells, and it's something that your liver makes. So if you don't have any, it might mean that your liver isn't working properly, or if you have too many, it might mean that you're breaking down too many of your red blood cells. Protein. Protein is not normally in your urine. It can mean a couple of different things. Protein can mean that you've got a urine tract infection. It can also mean you're in a little bit of kidney failure, because plasma proteins such as albumin are normally not filtered out by the kidney, but if you've got a kidney disease, you can start losing albumin, and your patients who have microalbuminuria might be your diabetic patients, for instance, and they're starting to get a bit of diabetic nephropathy. Your pH is just a measure of how acidic or alkaline the urine is. All the acids in your body, apart from carbonic acid, are excreted via the kidney. So there's just some of them. Okay, blood. Blood is not normally found in the urine. If it is, it means something's wrong. It's possible that if a female patient has been menstruating, there may be some sort of residual found on there, so it's important to inquire about that. But it can mean your patient may have an infection. It could also mean that there may have been some trauma to the kidney or the urinary tract. The patient may also have a tumour. It's possible. So there's a number of things that blood can mean. Specific gravity is how concentrated the urine is. So if your specific gravity is too low, you're not concentrating urine, and especially you would worry if it was too low if it was in the first morning void. So if you did a urine dipstick on the patient's first morning urine sort of production and the specific gravity was too low, that means that they're not concentrating the urine enough, which means that really they're in renal failure until proven otherwise. If your patient's dehydrated, the specific gravity will increase. So the first morning void, you'd expect to have an increased specific gravity just due to the fact that your patient's been asleep and hasn't been drinking. Ketones are a product of fat metabolism. They are excreted in the urine, and they're a sign really that your patient has been starved. So if you skip breakfast and we do a dipstick of your urine, the chances are you'll have some ketones there. There's actually ketotic diets that people go on in order to try and lose weight. It changes your body metabolism to start metabolizing your fat. They can be quite successful. The long-term effects of this aren't really well known, because ketones themselves are acidic, and you don't want to sort of like be going around and being acidic all of the time, because it just isn't good for one. Bilirubin, okay, this is made in your liver, and again it can be a sign of breakdown of red blood cells. And glucose, again, this is not normally found in the urine, and if you do see it, your patient may have diabetes. So management of urinary tract infection is with antibiotic treatment, pain management, and increase your patient's fluid intake. And there's the Institute of Medicine's water intake recommendations for everybody. Just let you have a little look at that. So recurrent urinary tract infections, what we've got there is a urogram. So your patient's been given some radio contrast dye, so you can have a look at the kidneys and the ureters and into the bladder, just to see if there's any blockage or any stenosis anywhere. So recurrent UTIs can be due to a relapse with the same strain of organism, or reinfection with a different organism. It may require further investigation, such as a cystoscopy. A cystoscopy is where you do an oscopy. You put a telescope into a part of the body, and cyst tends to pertain to bladder, so bladder camera. So cystoscopy is putting a camera into the bladder to have a look around. Likewise, you can have an arthroscopy, where you put a camera into a knee, so you can do a knee arthroscopy. You can have a gastroscopy, where you put a camera into the abdomen. You can have a colonoscopy, where you put the camera into the colon. Further investigations is a urogram, which I believe that may be, and others. And there are some nice guidelines there regarding the treatment of urinary tract infections. And as this will be a movie, what you'll need to do is just type in UTI nice guidelines into Google, and they will be presented to you there. So further investigations, you can have an ultrasound, which can look directly at the structure of the kidney, the ureters and the bladder, and there's an image of an ultrasound there. You can have an abdominal x-ray, can be used to diagnose renal stones, and I think I can see a renal stone on the right there, possibly. You can do a cystoscopy, which you mentioned on the previous slide, which is direct visualization of the bladder. You can do a MCUG, which is a micturating cystourethrogram, to look at your patient's urine flow. This visualizes the flow of urine via a radioactive contrast dye in a catheter. You can do a DMSA, which is a dimercaptosuccinic acid scan. This uses an injectable radioactive isotope into the patient's renal tubules. And you can also do an MRI scan to look for tumours or renal stones. Okay, after all of that, a quick end of session quiz. What do these words mean? Micturation means having a wee. Hematuria means blood in the urine. Glycosuria means sugar in the urine, glucose in the urine. Anuria, remember A means without. Anuria is no urine, as opposed to polyuria, which is much urine, or oliguria, which is a little bit of urine. Diuresis means to have a lot of wheeze, lots of micturation. Enuresis is to how can I put this, be incontinent, to wet oneself. There's nocturnal enuresis, which is bedwetting. Ketonuria, where ketones are found in the patient's urine. This is a sign that the patient has had, has been starved, so they're metabolizing fat rather than using normal body things. Nausea. What does nausea mean? It means you feel a bit sick. Okay, and the rest we just put on all at once. So oliguria, we mentioned that just a couple of seconds ago, is a low urine output. Dysuria is difficulty or painful urination. Okay, polyuria is many wee-wees, so it's passing lots of urine. Pyrexia is having an increased body temperature. Remember, your normal core body temperature is 37 degrees Celsius, and the reason it is 37 degrees Celsius is because that is the optimum temperature for enzyme reactions to take place. And if you get invaded by a pathogenic organism, your body will increase the thermostat to have you at 38, 39, 40 degrees in order to make it a bit more difficult for the bugs to breed. Equally, it's more difficult for your cells to go about their cellular things. That's why when you have a pyrexia, you tend to feel dreadful. Precisely what the definition of a pyrexia is remains open to a little bit of interpretation in the literature. Generally speaking, it tends to be described as a temperature greater than 37.5. Okay, urinalysis means to look at the urine and analyze it and see what's in it. There's a couple of slides there where we went through what was on a dipstick. That's very important to get to grips with. Proteinuria means you've got protein in the urine. Cystitis means you have an inflammation or an infection in your bladder. And pyelonephritis is you have an infection or in your renal pelvis as well. So there we go. Hopefully that's expanded your vocabularies. Now some references for you, some absorbing reading. A good website to visit is Clinical Knowledge Summaries. So just type in NICE, as in National Institute of Clinical Excellence, NICE Clinical Knowledge Summaries, and you can pick any disease and it'll give you the NICE guidelines as to how you're supposed to treat that disease in a nice case study summarized format. Really, really good. So thank you for listening. Continue to be awesome.